A warm, hearty welcome to our esteemed cornea specialist. We have Dr. Matt Oliva with us from Seattle, Washington, HCP's board member par excellence when it comes to surgery, clinical, and just the most incredible human being. We also have with us today Dr. Noor from Bhutan. You are the only cornea specialist in all of the country of Bhutan. Is that correct?
Yes.
Yes. And so we are so honored that you are here with us today. Today represents a book review with questions. We are very grateful to Dr. Audrey Rostov. It is the resident who gets the most number of questions right in the fastest amount of time. That will be awarded a brand new penetrating keratoplasty set. We've gone through chapters 1 through 6 on November the 10th, together chapters 7 through 12 on November the 24th, and chapters 13 to 16 on December the 8th. You have had an accumulation of experts from the United States, from Nepal, from Ghana, today from Bhutan, who will be teaching you and be behind you not only through the rest of your residency, but into your career. And we hope that you will take advantage of that opportunity to reach out to them and learn from them beyond this classroom setting. As a highlight to the chapters that we have gone through in this book, they are chapter 1, structure and function, chapter 2, approach, techniques, and devices, chapter 3, ocular surface disease, chapter 4, associated eyelid conjunctival, chapter 5, therapeutic interventions, chapter 6, congenital anomalies, chapter 7, degenerations and depositions, chapter 8, corneal dystrophies, chapter 9, corneal ectasias. Chapter 10 was systemic disorders. Chapter 11, viral infections. Chapter 12, bacterial, fungal, and parasitic infections. Chapter 13, immune-related disorders. Chapter 14, neoplastic disorders. Chapter 15, toxic and traumatic injuries. And chapter 16, corneal transplantation. And we have gone through all of those chapters with you. I am going to now place a link to the 18 questions on the group chat. That will then be your quiz. So with that, good luck. Super job. Congratulations to those of you who have submitted your answers. We will get started with Dr. Matt Oliva coming to us all the way from Seattle. So early in the morning, I believe, Matt, it's 7:30 in the morning for him, now almost 8 in the morning on his daughter's 18th birthday. And he said that he wants to be with all of you. So many thanks to Dr. Oliva for being with us today, giving us his pearls. He's going to go through questions with you. After each question, he's going to explain it. Experts in the room, please unmute yourself. Dr. Audrey Rostov, Dr. Noor, Dr. Detchen, feel free to unmute yourself after that and give your pearls of wisdom on those lessons.
Namaste, salam. Good morning, good evening, everyone.
Very
Ashiyana, thank you so much for the opportunity to be with you all. This is really a remarkable community that we have in this virtual space with doctors from Nepal, the Kingdom of Bhutan. Thank you, Noor, for being here. Ghana, Ethiopia, and I've had a chance to work with many of you in this room, and I really look forward to the opportunity to work with all of you as you go on your journey in ophthalmology and help so many people. And cornea, I'm a cornea specialist. Dr. Taban is also a cornea specialist, and I've had the pleasure of working with both the eye bank in Nepal and also in Ethiopia. And so You're also lucky as a cornea, people that are interested in cornea, because to my knowledge, those are two of some of the greatest eye banks in the world. I mean, it's rare in Africa. I don't know of any other functional eye bank, and the Nepal Eye Bank serves not just Nepal, but really the entire region. And there's also some wonderful leaders in all of the countries, Dr. Larty, Dr. Menon, Dr. Jonas, Dr. Jaffer, and Jimma, of course, Dr. Noor in Bhutan, and my good friend, Dr. Rita, Dr. Lena, who's been with you, Dr. Rachana in Nepal. So I hope all of you share the love of cornea, and I'm sure you guys aced the test. I look forward to seeing Ashiyana's scores, but I'm just going to give some overview. Chapter 1 is about the structure and function of the external eye and cornea. And the point of this slide is that it's super complex. And we know a lot more than we did 30 years ago about the basic science. So when you're treating patients, you need to not only be thinking about what the eye looks like, but the various, understand the anatomy and understand the physiology of the surface of the eye. So question 1 was something that we look at and see at the slit lamp every day. What are these structures? And the answer is the palisades of Vogt. This is not to be confused with Vogt's striae, which is probably Dr. Vogt described a lot of things, but Vogt's striae are in keratoconus in the deep stroma stress lines. The palisades of Vogt are these series of radiating ridges that occur at the limbus, and they're where the bulbar conjunctival epithelium and tenons merge. And why are they important? They're important because this is where the epithelial stem cells reside. So a very critical reservoir of cells that, if they're damaged in a chemical burn, for example, or from too much contact lens wear, can lead to long-term problems with maintaining a healthy ocular surface. So question number 2, which of the following serve as the sentinel cells of the immune ocular surface and sensitize naive T cells? And the answer here is the Langerhans cells. So the immune system is important because when there's deviations of it, there can be a lot of disease processes, specifically chronic inflammation on the surface of the eye. So the Langerhans cells are specific antigen presenting cells that are everywhere in the body, but they're in the conjunctival epithelium and also the corneal epithelium, and they serve as to uptake the antigens, and then they're really the sentinel cells are kind of the generals of the immune system. And in the cornea, they're out in the periphery. They're not in the central cornea. They're out near the limbus, and they can be seen in this micrograph. When Langerhans cells, there's a tumor you probably remember called histiocytosis that is from a Langerhans cell deviation. So question number 3 is about the tear film, and the tear film contains a mixed mucin aqueous layer produced by all of the following except the subepithelial plexus, which is basically nerves. So the nerves are not creating the mucin of the aqueous layer. This is a schematic that talks about the tear film, and the important thing is to understand that there's, once again, it's complex, that all dry eye is not created equal. There's 3 basic layers: the mucin, the aqueous, and the lipid layer. You can see that the corneal epithelium has a little microvilli that interact with the glycocalyx, where there's then mucin and aqueous on top of that glycocalyx, and then covered by a lipid layer. So what is the function of the tear film? The tear film's critical. It's if you want good vision, you have to have a good tear film. And I see so many patients after cataract surgery, which disrupts the tear film, complaining of, fluctuating poor vision, because if there's dry spots on the cornea, you're going to have not good quality vision. So it also removes irritants and has a defense function with lactoferrin and defensins and matrix metalloproteinases. It also facilitates diffusion of oxygen to the cornea. So if you have a poor tear film, the cornea is not going to be healthy, and there's going to be problems with the vision. So.
Hey, Matt.
Yeah.
Hi, it's Audrey.
Hey, Audrey.
Hi there. Hi, everybody. I also wanted to add one other interesting thing here. If you think about it, as Matt is going through all of the functions of the tear film and what produces, adds to the tear film and what doesn't in terms of mucin, that subepithelial plexus layer of nerves. Sometimes you can get these patients who have what's called pain without stain. And that is a neurotrophic dry eye syndrome. And so you're not going to get the same type of staining that you'll see when it's something that interferes with the mucin layer or any of the tear components. However, they can have a lot of pain and dry eye type symptoms. So if you see pain without stain, then you want to think that that's really the subepithelial plexus. That's more of a neurogenic type of, in quotes, dry eye disease. And that's why it's important with this slide. And then you could really understand it as Matt is going through all of the excellent points about the tear film, about the difference between sort of true dry eye, if you will, and then when we get a neurogenic, a neurotrophic dry eye of pain without stain.
That's an excellent point. And the other thing too, I want everyone to sort of take away, right, is that Matt brought this up, the air tear film interface, right, is not only an important refractive, powerful surface in the eye, it is the most important refractive power of the eye. Okay, so when you get the question, which is the most, important aspect of the refractive power of the eye, it is the air tear film interface. Sometimes they'll trick you by saying just tear film, or just air, or lens, or cornea. The answer is the air tear film interface.
Yeah, great points. Thank you, Audrey, for bringing that up, and Ashiyana. Dry eye comes in all sorts of different types, and there's some people with a lot of findings and not many symptoms, and then there's a lot of people, vice versa, is true. A lot of findings, no symptoms, or a lot of symptoms and no findings, and so you need to really have a comprehensive understanding of dry eye. And there's different types, which you all know. The tear film, this is a commonly tested, question. What are the three layers? Ashiyana in her talk, gave a mnemonic, LAM, which is the top lipid layer, aqueous, and mucin is the bottom layer of the tear film. So the way I like to explain the lipid layer to patients is I imagine like a oil slick out on top of a body of water. And if you can imagine, the lipid layer prevents evaporation. So if the oily tears are poor, you're going to get increased evaporation of tears. And usually people are, complaining of fluctuating vision or sort of eye strain. And we see this a lot, with people staring at their phones and devices all day, where the blink rate goes down and the lipid layer is poor. So a lot of tear replacements really focus on the lipid layer, and then the aqueous layer, of course, is more of a Sjogren's type syndrome, which we'll go into. But LAM is a good mnemonic. All right. Excuse me. Moving on to chapter 2. So we all hopefully have access to fluorescein. There's also other stains like lissamine green or rose bengal. As Dr. Taven pointed out, rose bengal and lissamine green tend to be a little more irritating to the eye. So most people sort of stick with fluorescein that are more widely available. But you can tell a lot about the mechanism of dry eye based on how the cornea shows up with these stains. So which one is most commonly seen in dry eye disease? The answer is C. And this is an interpalpebral staining pattern that's also can be seen in exposure or neurotrophic keratopathy. Really what I'm kind of looking for is the top one more of a toxicity problem, and then the inferior and the lower conjunctivus staining patterns. I think about more either the eyelids not closing, like a lag ophthalmos problem, or the meibomian glands and the eyelid is interacting in a way with the cornea to cause eye disease, usually kind of inflammatory, the meibomitis, blepharoconjunctivitis staining pattern. But the pure line right across the cornea is a more indicative of dry eye disease. Question number 5. So this is about imaging and specifically the benefits of ultrasound biomicroscopy over anterior segment OCT. And the answer is that a UBM can allow visualization of structures through an opaque cornea. Anterior segment OCT is high resolution, low frequency imaging of the anterior segment. So it gives really great details of the cornea and the front of the eye structures, but it doesn't penetrate very deeply, specifically beyond the iris pigment epithelium. So anterior segment OCT is great if you are trying to see if your DSEC graft is attached or your DMEC graft is attached. Or you're trying to understand where in the cornea, how deep an infection is, or how deep a LASIK flap was made. It also can give you some good information about the angle. It's easy, it's quick, it doesn't require a contact lens on the eye. UBM requires a contact lens on the eye and is more high frequency but lower resolution. You can see in the picture is much more blurry with a UBM, but it gives you information behind the iris pigment epithelium, so you can see if there's a ciliary body melanoma behind the iris, and you can also see for ICL, so sizing, it works very well. But a UBM, if you have someone who has an 8-ball hyphema and you want to see if the lens is in front of the iris or the lens has been dislocated into the back of the eye, a UBM will give you that information, even if the cornea is blood stained or so that's kind of but they're harder to find and require more operator skill, UBM, than an ultrasound OCT. Any other comments from the other experts on this?
I also want to mention that with anterior segment OCT, ocular surface tumors and ocular surface lesions can be distinguished. And I think that that's an important pearl. We have at Tilganga an ultra high resolution OCT, and we have given lecture to those residents in Nepal about the uses of it. So I encourage you to practically utilize that. But distinguishing a pterygium versus a Salzmann's nodule versus an ocular surface squamous neoplasia, and so forth can be done using what we call an optical biopsy. And what is that? Basically, without having to actually use your blade, you can distinguish one lesion over the other using anterior segment OCT, and specifically ultra high resolution anterior segment OCT.
Great. So question number 6, what key factor is evaluated in corneal tomography and not in topography? And this is an important one. So basically, what's the difference between topography and tomography? It's imaging of the posterior cornea. So corneal topography, most corneal topographers are based on a Placido disc technology, basically taking rings and looking at how they're reflected by the cornea. And they give you information around the shape and the power of the anterior cornea. And these are the types of printouts that you see. The tomographer, though, is an entirely different type of a machine, and there's basically a couple different types. So one is the original one was called a orb scan, and it's a horizontal scanning slit tomographer. That's been largely replaced by a Scheimpflug imaging, specifically the Pentacam is a well-known machine, and this is a Pentacam that looks at on the left-hand side of the picture, the front of the cornea, and then the elevation of the back of the cornea, the corneal thickness over in the cornea, the K max, which is important if you're looking at keratoconus. And then this is an important algorithm that was developed by Renato Ambrosio and Michael Balin called the Balin-Ambrosio indices. And these little red boxes down here basically are measures of abnormalities of corneal shape outside of the norm. So they're looking at a normal distribution of corneas and looking for peculiarities of shape. And another question that may come up on tests is, where does keratoconus start? So this is a really wonderful screening tool for keratoconus, specifically if you're looking at doing refractive surgery or trying to understand a young person with a lot of astigmatism. Does this person need to have collagen cross-linking? A tomographer will tell you on the, you'll see a red spot on the back of the cornea, because keratoconus typically starts at the back of the cornea with elevation of the posterior float. So you're not going to get that information. A person could have an abnormal posterior corneal curvature and have a completely normal anterior curvature.
I'm just going to interject one thing there, and that's that it's important, if you are using a Pentacam and looking at your Balin-Ambrosio display, that it is only suitable for this display for virgin corneas, so corneas that have not had refractive surgery. If it's a patient who's had previous refractive surgery, this algorithm doesn't work. And so if you have someone with previous refractive surgery and you do this, everyone's going to look like they have keratoconus because it's not valid. It's only valid for the unoperated cornea. And if you have somebody who's had refractive surgery or somebody with a cornea transplant or something like that, you're not going to get valid information. And so that's something to keep in mind. The other thing is that this will detect a lot of keratoconus. Again, in the virgin cornea, as someone who's not had surgery before. However, not all keratoconus. And sometimes you can get a suspicious report and it doesn't absolutely mean they have keratoconus. They may in fact not have keratoconus. And conversely, even if you get a completely normal report, the patient can still have subclinical keratoconus. So it's important to take a look at everything, the clinical history, a family history. Is the patient an eye rubber? Taking a look at the tomography, and also we'll get more into this in the next chapter in refractive surgery, but epithelial mapping as well. And so it's all of these things put together.
Great points, Audrey. And also, the other thing is that Pentacam Scheimpflug is a little bit less sensitive to disorders of the ocular surface, whereas a placido disc is highly, if you have a really poor surface, you're going to get distorted information from that too, is one other sort of pearl.
Matt, if you can
All
just
right,
go back 2
go
slides
ahead.
onto the corneal, onto the pentacam. As a cheat sheet, you know, when you look at this, sometimes you get overwhelmed initially when you start to read these, but when you're looking for keratoconus, I don't know if this was brought up, so forgive me if it has, but if you look at those 6 maps on the left and you're not sure where to even begin with all the colors, I always try and look at the bottom right. That's the posterior of posterior cornea. And if I see red there, okay, so here you can see Matt showing us the red there, then that's like there's some form of ectasia, be it post-refractive, keratoconus, keratoglobus, and so forth. So that's one thing to look at. The other thing is don't forget with your pellucid marginal degeneration, you will look for a crab claw appearance, okay? A crab claw appearance on the anterior surface of the cornea. And keratoglobus, you look also at the level of thinning. And if the level of thinning is diffuse across the cornea, then really think about keratoglobus as a distinguishing differential diagnosis to your keratoconus, where you have inferior steepening. Okay, so those are some additional pearls for you.
Although you can still get a crab claw appearance with keratoconus. So you, again, that's where you really have to look at the clinical picture of like the tightened belt with the belly hanging over for true pellucid,
Yes.
which is much more rare versus keratoconus. So you can still see in the inferior steepening or a crab claw appearance even with keratoconus.
Really good point. Really good point, Audrey.
All right, so which of the following eyelid findings is defined as a blister filled with serous fluid? So this is a vesicle. So, you know, these are important distinguishing findings to know. When I think of a vesicle, really what I'm thinking of, my mind goes is to a viral process, such as specifically herpes simplex or varicella zoster keratitis. So whether it's a vesicle on the lid or a vesicle on the cornea, vesicle, I'm typically thinking virus. But it's a little bit of a bulla is a large blister, and like a bullous keratopathy is a water blister. Vesicle, I guess, would be serous fluid caused by a virus. Question number 8, which of the following is not in the differential diagnosis of an endothelial keratitis? So the answer here is acanthamoeba keratitis is if you see endothelial, specifically keratic precipitates, acanthamoeba wouldn't really be the number one thing you should be thinking of. And I think that what they're getting at with this question is specifically, you know, when you see subtle KP in someone with a red eye, I mean, obviously if they've had a corneal graft, you're looking, you know, thinking about immune rejection and looking for KP that are on the back of the cornea specifically, back of the corneal graft specifically. Endothelial keratitis, most, you know, herpes simplex and varicella are super common eye diseases. They actually usually start at the endothelium, although can become a stromal keratitis as well. Acanthamoeba is a completely different disease process. Acanthamoeba is a protozoan infection. Usually it's in contact lens wearers that or people with compromised surfaces that then are around water, sometimes like in flooding areas, people can get acanthamoeba if there's brackish water, but the protozoans get into the cornea and kind of, you know, typical findings are with an acanthamoeba would be severe pain, a paraneural infiltrate out in the periphery of the cornea, and kind of a ground glass appearance. It oftentimes masquerades as HSV and epithelial keratitis, but kind of a completely different disease process. Question number 9. In dry eye disorders, Sjogren's syndrome is classified as, the answer is A, aqueous deficient dry eye disease. So, when Sjogren's syndrome is more of a autoimmune condition. Dry eye, dry mouth is kind of the two hallmarks of a Sjogren syndrome, or an aqueous deficiency. And most dry eyes actually can be a combination of both an evaporative process, meaning poor meibomian gland lipid function, as well as an aqueous. But it's important to understand what's an aqueous, and that this can be, by history, and also serological testing for, it can be done for aqueous deficiency. And there's some 3 or 4 different blood tests that can be run. And the important thing is to understand that it may be associated with systemic autoimmune conditions, specifically rheumatoid arthritis, and then would be by far the most common one, and then other secondary causes. Audrey or Nor, Ashiyana, you have any more comments on maybe how you work up Sjogren's syndrome, or how you differentiate Sjogren's syndrome versus meibomian gland evaporative loss?
I would say another thing to keep in mind is vitamin A deficiency. If you're seeing someone with a really, really severe dry eye, so whenever you see, not just kind of run-of-the-mill dry eye, which would be, they have some SPK, and maybe you have a look and you see their meibomian glands. Again, always go by the clinical examination. Their meibomian glands look like they're a mess. They're irritated, or you squish on them and there's stuff coming out. And then you say, okay, well, that person probably has either a mixed dry eye maybe, or they have meibomian gland dysfunction. But if their lids really look pretty good, and they have they're really inflamed, the conjunctiva has injection and it looks inflamed, and you have more diffuse SPK, then you really have to start to think about a systemic disease. And of course, all of these things that Matt delineated, you want to think about, do they have Sjogren's, get some Sjogren's antibodies? Do they have RA? Do they have another autoimmune disease, or do they have vitamin A deficiency? And I think that those things are important to keep top of mind.
I think it's very important that we all, spend a lot of time learning dry eyes, because guess what, friends? Dry eye disease, whether you're a retina specialist, a glaucoma specialist, a comprehensive doc, you are going to see dry eye disease in your clinic day in and day out, right? It's a cause for depression. It is a silent condition. Sometimes you're not seeing ocular surface stain when you're putting fluorescein into the eyes. And so that is why there was a whole dry eye workshop, the TFOS workshop, just to come up with the definitions, with the diagnosis, the pathophysiology, and treatment. And so this is a very important section of the book that I really want you all to pay attention to. Beyond that, I think it's very, very important, as Matt brought up in a previous question, is history, right? When you see patients with dry eyes, try and understand why. Yes, we know that the older we get, there's that risk factor. Women, Audrey and I, compared to Nora and Matt, we are at higher risk than the men in the house, right? But if you see something that just doesn't make sense, then you should ask the questions. When did this start? Is this a new thing? And do you have dry eye associated with dry mouth, right? With Sjogren's syndrome, you have to always ask the questions. Do you have the ability to take a piece of bread and swallow it, or chew it rather, without having to take a sip of water? Is that possible? Do you have dental cavities, caries, right? These are important questions. And then when it comes to a high suspicion, which can happen through a questionnaire that happens in your clinic, there's a number of questionnaires that are available out there, or through your personal questioning of the patient. If the suspicion is high, then definitely ordering SSA and SSB antibodies, and also getting a rheumatologist, if you have access to a rheumatologist, to help you corroborate these patients and start immunosuppression under their care is also very important.
All right, thanks. I'm gonna kind of move along a little bit quicker just because I want to make sure and give Dr. Noor time to cover his slides. So question number 10, which of the following has been associated with floppy eyelid syndrome? This is associated with obstructive sleep apnea. Floppy eyelid syndrome is most commonly obese patients where there's a mechanical issue. Oftentimes the eyelid rubs against the pillow. It can be on one side or the other, depending on sleeping habits. Usually just you can just take one hand and flip the lid at the slit lamp, or just by pulling up on the lid will flip. It's not subtle. You get this sort of red eye with a lot of mucus and this sort of velvety, very, very fine papillary change. And really it's a friction issue. These patients need to be worked up for obstructive sleep apnea, which can lead to increased mortality rates. And the differential is as seen in this slide. If it's bilateral and they have severe allergies, you need to be thinking about an atopic or a vernal process. Question number 11, what is this condition? I don't even recall what Lish corneal dystrophy is, so I didn't choose that one, but this is a epithelial basement membrane dystrophy. It has a lot of different names. It can be EBMD or ABMD, anterior basement membrane dystrophy. Also goes by the more common name, which I use to describe to patients, map.fingerprint dystrophy, because it looks like I stuck a fingerprint and smudged it on the cornea. Which of the following can be associated with a follicular conjunctivitis reaction? This was not also my favorite question because I think it's easy to, I think basically all of these could potentially cause a follicular conjunctivitis, but I think what they're getting at is, follicles versus papillary conjunctivitis. And the answer here is atropine, but, follicles versus papillary. When papillary conjunctivitis, I'm thinking of bacteria, I'm thinking of allergies. Follicles, I'm thinking of viral infections, specifically adenovirus, molluscum, things like that. Atropine, sulfate, not sulfate, is commonly used, to treat children when they're for amblyopia treatment now, and if that can cause basically a toxicity to the surface of the eye. But many times the difference between papillary and follicles can be difficult to tell clinically, and there's kind of a mixed papillofollicular process. So chapter 5, this has to do with options for when you have chemical injuries or other things that cause limbal stem cell deficiency. What are some surgical options? A bit of a word salad here, but Dr. Tabin did a good job of showing some videos to talk about selective limbal epithelial transplantation, which is a procedure developed in India that is quite slick, in which a limbal epithelium is harvested from the healthy eye and then made into little tiny particles, and then with the combination of fibrin glue and amniotic membrane used to repopulate the surface of the affected cornea. So it's one eye to the other process, much like a conjunctival limbal autograft. Question 14, which of the following represents a possible treatment for recurrent corneal erosions? So this kind of goes back to the anterior basement membrane dystrophy slide. The answer here is all of the above. I like to explain to patients that MAP fingerprint dystrophy has and recurrent corneal erosions have lots of treatments because there's not one that's a great treatment or a perfect treatment that completely solves the problem. I also always state that this is usually never vision threatening, although it can be really frustrating. I think the treatment, the sort of pearl there is understanding which what is there recurrent corneal erosions from like a fingernail injury. In that situation, I'm thinking more doing stromal puncture if it's a focal defect. If it's more of a diffuse MAP fingerprint inherited dystrophy or diabetics, I'm thinking more epithelial debridement with a diamond burr. Excimer laser can also be helpful.
Another pearl there is when it comes to refractive surgery, which you will have on January the 5th, is that PRK, right? PRK, photorefractive keratectomy. If you had to do, you have to be very careful in the patients that you see with EBMD because of the risk of recurrent corneal erosion. And when you go in for refractive surgery, you can actually exacerbate things. But doing a photorefractive keratectomy as compared to LASIK or SMILE, there you're actually treating EBMD and also treating their refractive error. So sometimes when you see a patient with EBMD, by chance, the patient comes in for you for getting rid of their glasses. Best option of the three, overall, generally speaking, would be PRK. So that is another important.
Great point. Yeah, don't do toric lenses in people with bad MAP fingerprint dystrophy. It would be another pearl.
Yeah,
right,
unless you do a superficial keratectomy first, in which case you can do the superficial keratectomy, let it heal up 4 to 6 weeks, retake your biometry and measurements, and then go ahead.
Exactly. Final question: what surgery is this? And I zoomed ahead here, but or which of the following indications can this surgery be used for? So this can be used for C. If an eye is Tysical, it can then be a Gunderson flap can be done, a conjunctival flap can be done, and then a scleral shell prosthesis worn over the sort of end stage eye. And this is a really good technique to know for a lot of problems that it involves, turning the eye down, harvesting a superior conjunctiva, a very thin layer of conjunctiva with a bucket handle configuration, and then using bicral sutures to cover the cornea. And this can be used to treat unstable corneas that are very thin, or infections, or non-healing epithelial defects. You can do small Gunderson flaps as well. And this and a tarsorrhaphy can be really helpful for intractable ocular surface problems. And I'm going to turn the screen over to Dr. Noor now and let.
Anyway, after having met Dr. Ashiyana in Nepal, Kathmandu, so I didn't know this program. So finally, she asked me to join this. This is my first. Last time I joined, but I didn't interact much. But this is my first time. So I'm not that an expert, I should say, because I'm the only one, and I have all the experts here. Yourself, Dr. Ashiyana, Dr. Audrey, and Matt. So do back up on me. I'll try my best and to do justice to the questions here. Which of the following ocular condition is not associated with microcornea? So the answer is actually three of them in the above are associated except for pigment dispersion. So When you say, I think here the question is trying to find out the cornea, which is different size and shape we are born with. So we have to differentiate from normal to abnormal. So normal in a newborn, it should be around 9.5 to 10.5 in an infant. So whereas up when it comes to 2 years old, I think most of us know that eyeball grows almost to a normal adult size. So that time it will be 10.5 to 12.5. And if you look at in dioptric, it's around 43. Now, when we say microcornea, it should be like in infant less than 9, and in the above 2 years of age should be less than 10. And usually in microcornea is flat, so they are kind of hyperopic and flat. Megalocornea is something that is abnormally like bigger than the normal. So anything that is above, like in infant is above 12 and adult is 13 and above. And when you say megalocornea, it's big, therefore it is steep, it kind of bulges out. Now there's another condition called cornea plana. The diameter dimension is variable. So usually it's very flat, and dioptric power, if you look, is very low, 30 to 35 diopter. Next. So by definition, I think, so one thing we have to keep clear in mind is differentiate microcornea, the small cornea we are discussing, from microphthalmos and nanophthalmos. Now the interesting, microphthalmos is a small globe, but inside the anatomy, everything is malformed. Whereas when it comes to nanophthalmos, it's a miniature or small eye, but everything is normal. So like we can differentiate using ultrasound imaging and through Excel measurements using ultrasound. And etiology, next slide. In the next one, so microcornea, important ocular enamel associated microcornea are all of the here, and what we are not what we have to keep in mind is like persistent fetal vasculature, optic nerve hypoplasia, congenital cataract, anterior segment disease, all of them are together will be there in a microcornea conditions. And systemic, when we say microcornea, we always look at systemic condition also. Like there's a condition called myotonic dystrophy, where there's a kind of progressive general wasting of muscles, and this patient have a constant, they have weakness also, and they have that tone where they, once they make a grip, they have difficulty releasing it also. There's kind of myotonic dystrophy. Then you have that fetal alcohol spectrum of disorders, and one of them is fetal alcohol, where pregnant women around 5th trimester, I think they drink alcohol. When you drink alcohol, all these changes can occur when the baby inside in utero. Then you have that Ehlers-Danlos syndrome, where there's a hyper, distinct joints and all are really, they can bend it. Then another thing is achondroplasia, where the you have the cartilage and all are, they not properly formed.
Absolutely. And with myotonic dystrophy, remember the cataract that is associated with myotonic dystrophy, everyone should say in unison, Christmas tree cataract, right?
Yes.
Christmas tree cataract with myotonic dystrophy. And Ehlers-Danlos syndrome, right? It's a collagen disease, right? So everything is stretchy, right? Including the cornea. And so another association beyond microcornea with Ehlers-Danlos syndrome can be keratoconus as well.
Yeah. Now, the opposite of microcornea is megalocornea. So it's defined as bilateral non-progressive enlargement of cornea. So cornea is normal but large. So diameter is more or equal to 13 mm. And in infant is 12 mm in infant. Can we, okay, so ocular anomalies we need to think of is diaphanous iris translucency, because I think iris is stretched, and I think you have the translumination or translucent effect. Then there is also pigment dispersion because the being enlarged, I think that it rubs against the zonules. So then this one, pigment dispersion, is the one associated with the megalocornea, so not with the microcornea. And you have meiotic pupil, then the angle is not well formed and associated with cataract. Then since it is a big cornea and all, I think that the lens is not in the position, so we call ectopia lentis. Then I think it's also arcus juvenalis. So when you have big cornea, then we need to look for arcus juvenalis also. And then sometimes arcus juvenalis, when you look at the young adults, we say related to type 2, cardiovascular diseases, where we need to look at it also. But and one of the other causes could be that megalocornea. Then glaucoma, not congenital, can be associated because of angle, dysgenesis. So associated with systemic conditions are all these craniostosis, where I think that the scalp bones are joined before it is time. So that can give rise to abnormal protrusion of the skull. Then you have that frontal bossing that can occur. You have hypertelorism, then facial abnormalities, atrophy of the face, dwarfism, then some intellectual disability will be there. Then also, chromosomal abnormalities like trisomy of 21 leading to Down syndrome, Marfan syndrome also, then Alport, then osteogenesis, almost like all of them related to some kind of collagen also, and then mucopolysaccharides, carbohydrate abnormalities, then to poor tone hypotonia. If I think if other faculty can explain to this also, because I don't encounter much of them. So it's mostly a textbook which I read through.
Yeah, no, I think what's so interesting about this, right? If you look at it, right, it's difficult sometimes to memorize lists, and we don't want you to. We want you to understand it. But certain distinguishing features between microcornea and megalocornea, when you look at associated systemic associations, right? Microcornea has your Ehlers-Danlos syndrome, right? Versus megalocornea has your Down syndrome, Marfan syndrome, Alport syndrome, osteogenesis imperfecta. I think that is one starting point as to how you can kind of categorize it too. And now, since we're on the topic of cataract, right, it's important to note that with Down syndrome, right, you've got that blue cerulean cataract association. Alport syndrome, you have the association of anterior lenticonus cataract, right? So these are some of the buzzwords that you should keep in mind. Anterior lenticonus, Alport syndrome, Down syndrome, the blue cerulean cataract. So these are important things. You also have the Fleck retinopathies in the retina for Alport syndrome. Marfan syndrome, very important to know the different aspects of it, but ectopia lentis, right? Ectopia lentis, know the differential diagnosis. We're not covering that today, but know the differential diagnosis of ectopia lentis, and Marfan syndrome is one of them. Audrey, Matt, any other points?
No, I mean, mostly I've seen megalocornea, the times I've seen it actually in my own clinic has been with Marfan. So Marfan syndrome, megalocornea, ectopia lentis.
Super, super.
So next question 17 is identify the syndrome associated with these findings. If you look at the picture below, you can see that you have polychoria, and then you have that abnormality, and all these things are there. So systemic as well as ocular, this thing is there. So definitely answer is Axenfeld-Rieger syndrome. Initially there was difference, they had to mention as Axenfeld anomaly and Rieger's anomaly, but now it has come into a single term, that is Axenfeld-Rieger syndrome. So in this one, you have usually they are bilateral, and then there's a posterior ambrotoxin with iris strands attached to it. And I think everyone knows that posterior ambrotoxin is a prominent solvus line which come forward, no, attaches anteriorly, where like this solvus is where you have the trabecular mesoc and the descemet membrane junction where they come. So when you start seeing in the slit lamp directly, then that's called posterior ambrotoxin. Associated ocular anomalies usually have iris hyperplasia, correctopia, pseudopolychoria, and glaucoma. I think all the terminology are quite familiar. And associated system anomalies like skeletal, craniofacial, dental, umbilical anomalies, hypospadiasis are all usually part of this Axenfeld-Rieger syndromes. And actually it's hereditary, so it's autosomal dominant. So when we look at through the slit lamp, you can see in the picture there, the prominent white, ridge, and that is called the posterior ambrotoxin, and where that is the termination of descemet membrane and the trabecular mesoc. So in that, it's thickened and placed anteriorly and usually bilateral. And again, this is autosomal dominant, can be associated with all this. So the catchword here is, what is posterior ambrotoxin? And how is it occurring and when it occurs? So if you look at the conditions, you can say Axenfeld, Alagille syndrome, X-linked ectasis, familial aniridia, and all these conditions, you can see posterior ambrotoxin. But if you see with other systemic conditions like last time, polychoria and all these things, then Axenfeld-Rieger anomaly we have to keep in mind. Audrey, Matt, and all, if you have things to add on it, because these are, for us, is our growth rate has gone down, so pediatric population also less here, so we are not seeing much of all these cases. So
Same. I don't have any. I would rarely see these. Yes, except in the textbooks.
That's right. That's absolutely right. So, unless you're seeing a lot of pediatric cornea, these, or, pediatric ophthalmology, you may come across some of these, but it's important to note, right? Because when you see it, right, they say the eye is the window to the soul, or at least I'm going to say that eye is the window to eye is the window to the body, right? The fact of the matter is when you see a posterior ambrotoxin, you should know what it is. You should be able to understand it. Why? Because it has systemic implications, right? For example, when you see ectopia lentis, if you are just saying, oh, there's ectopia lentis, and you're not asking the questions of whether it's trauma or whether you have heart abnormalities, you're going to miss Marfan syndrome. And that is lethal if you don't identify that. So if you don't know posterior ambrotoxin on slit lamp, right, then you're going to miss out on Axenfeld-Rieger syndrome or X-linked ichthyosis or other, and so forth. So it's important to note that whatever you find, you may not know the answer at that time, but you should say, oh, wait a second, I can go back and be able to find it, because there may be a systemic association and you may be able to save someone's life. So that's the takeaway I would give.
The other congenital thing we see is Peters anomaly. So in the Peters anomaly, we have this iridocorneal adhesion, avascular corneal opacity. Now, type 1 is just corneal opacity, and in type 2, there's a iridocorneal, lenticular adhesion, these two. And in type 1, I think has a better prognosis in terms of management, whether you do penetrating keratoplasty, whereas in type 2, I think the prognosis is not so good, and it's also associated with the cataract, vascularized, both condition, corneal opacity can be vascularized also. And one of the differentiating features you can do is anterior segment UBM, which we discussed just before by Matt. In the corneal opacified condition, if you do antisegment UVM, you can differentiate whether the cornea is adherent to lens or not. No, if it is not, and only corneal opacity, which can be either central, eccentric, and all this thing, then it's Peter type 1. Whereas in terms of type 2, you can see the addition between lens and the cornea, and the prognosis is not that good also in the type 2. So that's what they are saying. Next.
I think we're done here. I would just say one more thing to that question about eye syndrome, because I know that was, that's something in the differential diagnosis. Eye syndrome, right? You should know what ICE stands for, ICE being iris nevus or Cogan-Reese syndrome, the C being Chandler syndrome associated with corneal edema, and E, essential or progressive iris atrophy.